Very good evening, and thank you for being here. I see Professor Jörg Hacker. Thank you, Jörg, for coming for this talk. I see the President, Professor Gerald Hogg. I was here for your inauguration, and also for the inauguration of this new building when Jörg took over as a President. I would also like to thank the organizers, Professor Wheeler, Lothar Wheeler, my good friend for a long, long time. Professor Suzanne Hartmann, I saw her this morning. I think she's somewhere here. And of course, the other one, Professor Tom Mittenleiter, I think he'll be here maybe tomorrow. And thank you for inviting me. And thanks, Regina, for the wonderful, actually a little embarrassing introduction, but nonetheless, I thought perhaps it's a standard thing. You know, while COVID took more deaths worldwide, one disease that keeps on taking deaths every year, every day, every second, and that's tuberculosis. The number of people who have died of tuberculosis, I don't know of any other bacteria that causes this huge disease. Perhaps some viruses, one virus perhaps has been able to cause that kind of a disease. So COVID has taken attention for right reasons. It has also created, as we just heard from my previous speaker, Aida, it created new paradigms of how we can fast-track vaccine development, paradigms of how we can beat the bureaucracy. I think these are very important paradigms. What would have normally taken 10 years to create a vaccine, it took less than 10 months to create a vaccine and to develop it. And to, as she rightly said, from vaccines to vaccination is a long step. And COVID proved that it could be shortened, reduced by tenfold. And that is the beauty of COVID, which I look at it. In India, we have seen that with COVID, the mortality with TB has been, people have not been recording because of the COVID problems, but it has indeed increased. And even people are suspecting, and I'll present some data about what could be happening. How do we think India is going to challenge, India is going to take care of this disruption in other comorbidities caused by other infectious disease, notably TB. And as I said, it was said earlier, TB is the largest number of deaths in the world that occur anywhere in one country. It is India. And so we have to have our priorities very clear. While COVID is a priority, it has been a priority. Today, we have also been able to see the results from us. How did we achieve what the world could also achieve, and what we as a so-called developing country could do this in a matter of less than a couple of years' time. So I must also tell you that many of my slides have already been presented earlier, not that the same slide presented, but the same data have been presented because some are common data. So please bear with me. And if I can move to the next slide. This is a very interesting slide that just tells you what's the scenario of it doesn't seem to work. Oh, I have to look here. Okay, good. I need to go back. Can you?
Yeah, it's work.
Okay, need to go back. Good. So this slide just simply tells you what's the scenario of COVID was. Sorry. I think I'll manage without this. It's easier to do it. So you can see that the dark picture is colored here, but look at the lighter color. This was an indication of a number of COVID cases per million. So India was along with the other places, other countries of the world, and that's the data as of June 2022. But if you see, okay, now I know. So if you look at the deaths we are now among the countries which had less number of deaths. And that is a topic that I would like to dwell a little more light. How did we manage it? We were countries which had much larger incidence of COVID, yet we had much lesser deaths, unlike some other countries where you may have restrictions in reporting deaths. But how did we manage this? And to look at it, the timeline has already been beautifully illustrated by my previous speaker, but I'll restrict it to Indian context. We had the first virus entry reported in January 2020, February, March, small clusters, and by March and early June 2020, a nationwide lockdown was implemented. It was also shown in the slide presented by Lothar Wehler, where he showed the long lines and the long, other things that happened during the COVID time. Second wave marched the Delta wave. Delta wave slide was also presented, a nutshell was presented by Lothar Wheeler, where he showed the number of deaths happening. There were unprecedented deaths and mass funerals taking place because we were not willing to accept didn't have the requirement to manage such problems. The Omicron came mostly B2 variant, and the third wave January 2022, and the fourth wave rising, which is the mix of Omicron sublineages. The first wave, early cases, January to March, long lockdown, March to June 8. And then, of course, finally, Alpha entered by January 2021. Later on, what we see, the Delta virus. This caused the largest number of deaths. It overwhelmed hospitals. And this actually woke up the political leadership. Before that, just about a few months before Delta, we thought we have conquered COVID. And we publicly announced that COVID is over from India. And we allowed mass gatherings, and that was a mistake. And later on, the government realized that I think that was a mistake, and we should not have allowed that. And we have seen the consequence of Delta: deaths, queues at crematoria, oxygen shortages. And these were all realities which the government put its act together and moved forward. So the third wave, which is January 22, was much less severe. And also because immunity had started to develop, vaccinations have been going on, and a lot of people have been vaccinated, including the vulnerable ones, and also less virulent variants where by that time Delta had given way to the Omicron and the other variants. Systems better prepared. I think that's more important. The government of the day realized that we have to prepare the systems. And every government, we have a federal structure and we have a state provincial structure. And they all gearing up the system for fighting the COVID. By the fourth wave, evolving in June 2022, increasing case counts and test positivity rates in the metropolitan cities. And today, there is a general feeling that COVID is not, if not gone completely, not as aggressive. And that the best way to monitor that is the absence of masks in the general public. However, when you take a public transport, the same way I saw here in Germany, mask wearing is compulsory. So that is a broad background. What was the focus? How did we manage it? One of the biggest things that the government of the day did under the Prime Minister's leadership was we had 4 departments: Department of Biotechnology, Department of Science and Technology, and the Council of Scientific and Industrial Research. All these 3 departments, together with the Indian Council of Medical Research, were involved in all human health-related activities. Their names may be different, but so each one of them wanted to be the nodal agency to do COVID management. The government said nothing doing, we'll have only one agency, the ICMR. So today, every place, every citizen of Germany knows what is Robert Koch Institute. Similarly, every citizen of the country, India, 1.3 billion, know what is ICMR. Ask them to expand ICMR, they will not expand. But they know ICMR is the one that managed the COVID pandemic. So that was a wonderful decision taken. We also started, the Prime Minister also started Ayushman Bharat, which means long live India. Life expectancy of Indians should go up. This was a gross level, and I'll give you a little more detail. And we also made use of a digital program. It was mentioned also in the morning by Lothar, where you need to combine digital media, not media alone, but digital, I would say, superiority with classical way of managing disease. And that is one of the success stories behind how India achieved what we could achieve. We also had a lot of efforts on screening, monitoring, and surveillance. We had phone apps. And some of the apps I will talk to you very briefly. Arogya Setu, which means let there be no disease at all. A bridge to prevent disease. Arogya Setu in English means. Covin, another app. And I'll tell you how these apps really helped India gain what we could achieve. Vaccine research, and I'll again tell you, many of you know that India is considered as the vaccine capital of the world. We heard just now the Pfizer vaccine but we have our own version of vaccines, and I'll tell you in more detail how we think we provided leadership not only to India, but we also supplied our vaccine. There was also a wonderful lecture in the morning where we said it's not just we should be healthy, but our neighboring countries should also be healthy, which means we should be able to send our vaccines, send our interventions in other countries which cannot. And I must say, Indian vaccines were one of the few vaccines that were being sent to different countries, underdeveloped countries, for use. And we also now, today, we have scaled up manufacturing, administration, and delivery. And as I said, India has emerged as a vaccine capital of the world for right reasons. 98% of our population received the first dose, and 91% both doses. I'm talking about not 1.3 billion people, but those who were qualified, those who were in the high-risk factors. We'll tell you exactly what. So there was essentially a political commitment and dedication. I talked about the interventions, surveillance, Arogya Setu, the bridge to health, so that let us all pass through this. This was a common platform, common app, more like on your app on your smartphone, and all it does will alert user if they come in proximity to an infected person. It's a wonderfully networked completely. Every single Indian, adult Indian or anybody, you can download this app totally free. It also informs users about best practices and relevant medical advisories. The app is privacy first by design, and app also has highly scalable architecture and is available in 11 regional languages. We have 23 different languages in the country. 11 of them are covered in the country with this app. Who can use it? You don't have to speak Hindi. You don't have to speak English or any other language. If you know your own language, you can use this app. So this was a beautiful part of it. And how did this app work? How did the Arogya Setu know about positive cases? Once a sample is collected at a lab, the collected sample is analyzed. The results are uploaded to the ICMR portal. And ICMR, if you test positive, it shares the details with Arogya Setu. And all this happens in a matter of hours. When I got my COVID, I can tell you, at times I was feeling, why did I go to get this testing done in a government laboratory? Because after that, I was under so much surveillance. Every 4th hour or every 3rd hour, I'll get a phone call. Sir, how are you doing? Are you okay? Sir, can I send an ambulance to you? Because they thought, I'm in a vulnerable age group. But that is the kind of intensity the government resorted to, and not just to me, but I'm told for everybody. That was, they were monitoring and ensuring, what is your oxygen tension level? What is your other parameters? Please advise us. And every 3rd hour, if you get this kind of a message, finally I had to put my phone off. So that is the kind of a thing Arogya Setu managed to do it. And the result was what we see, testing network in the country. Look at the testing network in the country. The right, you have the map. Almost every part of India had established a testing network compared to a single network that was started and directed by my wife, who was here at the National Institute of Pathology at the NICMR Institute. And then today, 3,300 COVID-19 government and private molecular testing labs, more than 7,000 RT-PCR. It was earlier done in a handful of laboratories, and today more than about 10,000 RT-PCR labs are working in India. And 12 high-throughput cobas sequencing machines, approved RT-PCR kits, 52 approved rat kits, 8 approved self-test kits. So this is how we could manage to do it. Upscaling testing facilities, laboratory in every district of India. So nobody can complain that I did not have access to it, and that is the key. Combine digital technology with healthcare providers. Marry them together, and that is what it was achieved. And medical colleges, all the district level hospital, we're talking about primary care hospitals where you do not even get electricity for the full 24 hours. They were equipped by with testing facilities, and you can get the results in a matter of hours, and then your results are shared with the Arogya Setu. So that was possible, and this is how it was achieved. Coming to the next part, the vaccine part. Today in India, we have the Covishield, which is the AstraZeneca vaccine. We have Covaxin, which is made by India, for India, but it was also exported outside to the country, many countries. We have Sputnik, which is Chinese vaccine. No, Sputnik is a Russian vaccine. And we also made world's first DNA vaccine. Zydus Cadila made it, a pharma company in India. And we also have mRNA vaccine, Genova, same thing what others have been making it. And very recently, the people who made the Covaxin also made intranasal vaccine, so you don't need to take a shot. That's enough. So you just do that and you are vaccinated. These are all remarkable basic science research discoveries that the government of India, and this was monitored directly. Imagine if the Prime Minister of a country goes and visits your lab, everybody feels alerted. That was a kind of leadership that was provided to combat COVID. Initially, we thought it's nothing, it's just any flu. But when we realized, especially after the Delta episode where we had thousands of people dying, we felt that problem. So the take home was, don't let the perfect be the enemy of the good. Don't worry about getting the perfect vaccine. Whatever vaccine you have, we'll figure out if it is perfect or not later on, but let's use that. And this strategy, friends, has really paid. It was also the best coronavirus vaccine is one you can get as soon as possible. And we could get as soon as possible not only the AstraZeneca vaccine, but also our own Covaxin. I got vaccinated by Covaxin, and I think I did the right thing. That was available to me straight away at that time. Vaccination is an important tool to help stop the pandemic. 98% population 18 and above are vaccinated. 91% are double vaccinated. Vaccines which cost $20 to $25 globally were initially sold at $4 to $5. Subsequently, the government of India immediately said, we'll give it free. So every single Indian is today getting vaccines free, including boosters. So that was a very major policy decision taken by the government of India. India exports its vaccine doses to help other countries too, and that's also all in record. So learnings, what are the learnings? Vaccine inequity, it was also mentioned in the morning by speakers, and it was a wonderful, I would not like to go more into it. Raw materials and ancillaries restricted, so we decided to create our own raw material, not depend on anybody else. And that strategy helped, because that was a time when we thought if we go and import the raw materials from other countries, we are at their disposal. And we decided that we will make our own everything, starting from raw materials to putting in the bottles, to the vials, to needles, to everything. And that was done. Global supply chains disrupted. India adopts the slogan of self-reliance, patent protection, battle at WTO, and I'll tell you the variants are the payback. I think these are the lessons. The ICMR COVID-19 vaccine, the first one was the Bharat Biotech, which is a Hyderabad-based company. And this was already went through several trials, several clinical trials. The Serum Institute of India, which is today considered as the world's largest vaccine manufacturer based in Pune in Western India, also has completed many of the trials. This was an early slide. And Zydus Cadila made the vaccine, which is the DNA vaccine. So all this were not only done in patient, but they were also corroborated by standard publications in some of the top journals of the world. And these are already published. So nobody can say the Indian vaccines are no good at all. They have been properly peer-reviewed and published. The COVID app, I mentioned, what is a COVID app? It allows it's operated by the Ministry of Health and Family Welfare at the central federal level. But anybody can have, I can have an app on my download on my iPhone. And it can allow me, to book a slot for taking vaccines in nearby areas. It will tell me where can I get the next. I was in the US about a few months ago, and I wanted to take a booster dose of the Pfizer vaccine. And I was told that you have to wait because you can't get a slot. You have to wait for 2 days or 3 days. But with this app, it's possible to tell you where exactly you can get it immediately. And that is why, because we had this so nicely networked, thanks to our digital superiority, if I can use the word. Its application is also meant for COVID facility level users to perform vaccinators, supervisors, and surveyors. So reliance on experts to tackle regular COVID surges. We use the data management through COVID app. It's a real-time vaccination monitoring. We use the data by ICMR to analyze the consequences, if any, on a vaccine, and immediately introduce a measure to stop those so that we don't further aggravate the problem. All this is possible because it's all digitalized. Imagine the entire 1.36 billion people having access to this kind of a digital platform. It was scientists to analyze infectivity and severity of variants and subvariants. And this is what the COVID portal could do: registration and scheduling of modules, vaccination facility, vaccination certificate. It will give you a certificate on your smartphone, so you don't have to worry about it. It sends you an app, a WhatsApp message or SMS message. And of course, wherever you want to go, you don't need to take a printout. So this is what COVID could do. This is how we managed to take care of that. We also did what is known as typical Indian traditional medicine. Several medicines were tried, and some of these have been already approved because we have a slightly different yardstick for Indian medicine, for licensing, final use, as compared to normal modern medicine. And this has allowed us to try a number of things. In parallel, there were a lot of controversy about plasma therapy. And we were one of the first country to show that plasma therapy does not work. And we published this in one of the top journals. I think it was there in New England Journal or one of the Lancet journals. So I think we did this. We made use of our Ayurvedic, that is the herbal preparations. And much of the people, including when I was having COVID, believe me, my oxygen tension never went below 97. And that was because I relied very heavily on herbal preparation, just making a tea out of that and drinking it every 4 to 6 hours, knowing fully well that unlike modern medicines where you have a single molecule targeting a single target, here you have a bunch of molecules which are targeting multiple targets. So, that is perhaps the reason why these Ayurvedic and herbal preparations work so effectively. So this is how we continued. And India took the bold decision to become self-reliant. From zero, India now manufactures 4.5 lakh, which means about 0.5 million PPE suits a day to fight coronavirus. Fortunately, we will not need to use this, but we developed the capacity. And we said, yes, we will be able to do this. All this after we had this debacle of the Delta problem. About 1.1 million genome sequences where sequencing was done by Department of Biotechnology and other laboratories, and many samples and many of these are available. Of course, some people do complain that Indian sequences are not available as freely as others. We have our own reasons not to do that, not to allow that, but anyway. So the question here is, are coronaviruses here to stay? Just this little while ago, I was reading the US president proclaiming that I think we have now almost eliminated COVID, yet we have few thousand deaths per year, per day of COVID. So I think coronaviruses, perhaps future pandemics could be even more lethal than COVID-19. May not be COVID-19, but I think this health meeting is for not only for COVID-19, but global health. COVID-19 has infected, as we just heard, 0.6 billion people and killed about 6.52 million globally across as on September 16th. Wiped out trillions of dollars in economic output, and the worst that we are now seeing is the earning capability of poor and people who were below the poverty line. And it has impacted, caused enormous economic upside down for billions of people around the world. Efforts to end the COVID-19 pandemic have been uneven and fragmented, marked by limited access to vaccines. This was the question I posed to the speaker in the morning, the discussion that time. And he's agreed that, yes, I think we do have this problem of uneven vaccine distribution, and I think it's important that I'll be healthy as long as my neighbor is healthy. And neighbor is not just my immediate neighbor, but neighbor also means my neighboring country, another country. I think this is a very important message. WHO has called for permanent funding and for greater ability to investigate pandemic through a new treaty. Let me now change gears and come back to my major topic, and that is the topic of the double whammy of respiratory pathogens. Global map, countries which have TB and COVID together, and India, as you can see, is very clearly in parallel. While COVID was going on, India started monitoring at other non-infectious disease, and we set up a national communicable disease non-communicable diseases have become top killers, and we have been doing we just heard a wonderful talk about obesity pandemic, which is also coming up. Fortunately, we don't have that yet in India. But we have diseases such as malaria, dengue, typhoid, diarrhea, hepatitis. And all this, we are now looking at it. And the good part is, India is the only country to have tertiary healthcare systems like ASHA, accredited social health activists to monitor women's health. And that is very, very important in a country like India, where women education and women's health is considered as a secondary thing and not a primary. And this approach is really showing a lot of good dividends. Look at the impact of Look at the impact of COVID. Look at the number of on TB notified cases. In 2020, it had a huge drop. Look at the total COVID-19. Look at the BCG vaccination, a huge drop. Now, all this is going to have an impact, and that is where I've listed in my abstract, how is it going to impact and how is India preparing itself for such an eventuality? There is a lot of impact of COVID-19 on TB. Tuberculosis has brought down the GDP of low and middle income countries by 2 to 3%. COVID-19 has brought down by 3 to 4%. So we are competing with COVID-19 in terms of the economic measures. Marginalization of services because of COVID-19, you can see a lot of services are being disrupted. You can see societal impact, health-seeking behavior of tuberculosis, HIV, diabetes going down. Unemployment, psychological distress, we heard a wonderful talk just in the pre-session about how psychological distress and substance abuse. Again, this is something that we have been looking at. Deleterious macroeconomic impact. The labor supply has gone down because the laborers were forced to move back to their villages, and now they are trying to come back. So this has overall impacted our economy, our health, our financial economy. The tuberculosis burden has gone up, the lower panel you can see. Catastrophic costs among patients with tuberculosis, and resources for tuberculosis program is also going down. Poverty, overcrowding, and malnutrition, all in a one leading to increased tuberculosis. So how are we managing this? We are managing this by one of the very basic thing is every single case of TB, if it is undetected, he or she will be the cause of 20 new cases of TB. While we have enough of technology, modern technology, the DNA-based technology, but in a primary healthcare center, when you do not get light, you do not get air conditioning, you do not get people trained enough, modern technology does not work. So we at the IIT Delhi, what we decided to do is to develop single technology which can convert an ordinary microscope into a fluorescent microscope, which is as good as a fluorescent microscope for a fraction of the cost. And then this has been automated. It can be linked to your iPhone, linked to your smartphone, and then you can get the result in a matter of few. Then there is, in parallel, another technology, which is the IMC square, immunomagnetic cell capture. It can capture the bacteria within the matter of few hours. You can sequence it, again, sequence the target gene, know which are the drug-resistant genes, and then go ahead and try. All this can be done at a level where you do not need to worry about air conditioning and trained manpower. The Government of India, the ICMR, has adopted this technology to begin with in the form of trying to try this. We have already published this in one of the Nature journals. We are trying to do this across the country in primary healthcare centers to see how this technology can be transferred. It's good to have DNA-based technology, but remember, we are living in a country where you can, the owners of the platform can dump the machine, but when it comes to giving the cartridges, it's expensive. So we have public primary healthcare centers where machines are available, but no cartridges, no users. You cannot. So that's where we find this kind of approach working very well. So learning from COVID-19 to tackle TB pandemic from despair to hope, implications of TB, COVID-TB co-infection, misdiagnosis, reactivation of latent TB during COVID infection, aggravation of an existing active TB condition, existing TB infection may escalate the risk and severity, and potential drug-drug interaction between TB and COVID medication administered during the infection. And like West, we also in India tried with many other drugs. Whatever we thought it's working in one patient, do it for everybody without understanding. And that was finally very effectively, scientifically proven that this does not work, including remdesivir and many other drugs which were initially being used randomly. So introduction of a bidirectional screening for TB and COVID-19, telemedicine for routine diagnosis, extensive community campaigns, doorstep sample collection, uninterrupted supply of drugs. This is a review that we wrote recently for The Lancet. Beyond Ayushman Bharat, India expanded healthcare system by setting up 22 centers of the All India Institute of Medical Sciences. It is easier. I don't know of any other institution in the world that getting into AIIMS is as difficult as getting into AIIMS. No other institution. Close to an unknown number, we can say, of people apply for just about 50 seats, and that is the prestige of these institutions. And the government of India decided, why should there be only one AIIMS in Delhi? Let there be 22 all over the country. Healthcare is free in government hospitals. Digitalize India Jan Dhan account. We have anybody can open an account sitting on your without even going to the bank. Of course, in here Germany it's easy, but imagine in India where people can't even read and write, they can do that sitting from there and transferring money. That was the power of teleconsultation for mental health, Sanjeevani for teleconsultation with specialists to a word diagram. So what are the gains? Increased investment in health, infrastructure, vaccines, equipment, stronger surveillance system, both rural as well as urban, which is very important. Rural is very important in the villages. One Health is prioritized. Role of frontline health workers recognized. Digital health and health technology, strong impetus to telehealth, efficient IT-aided management of vaccination program. The learnings have been false negative, false positive. How accurate is RO? We don't know. There are conflicting reports, so that's why we don't depend much on RO, which is a measure of how much of a virus are you, how infective is your virus. Non-Bayesian approach, clinical and contact history not used for prior probability. Asymptomatic and minimally symptomatic persons did not get tested. Hyped notion of herd immunity. That was also a notion that we believed it was overhyped, and we decided not to worry too much about it. Role of primary care neglected, prior immunity. And of course, contradictory message, masks, gathering, somebody said masks should not be, but now we know, no. The government has said, okay, you don't need to wear a mask in going to the marketplace, but when you are in a closed environment, mask, especially in public transport, masking is important. Fake news by all types of media, these are the gains. So the questions, can health and social systems prepare to meet future pandemics without lockdowns and social disturbance? That is a very important question, because this has a direct impact on the economy. Will national and global development pathways couple ecological sanctity with strengthening of public health systems? The take-home message is, post-pandemic world being more interconnected and digitalized, real-time sequencing data could be made more available across the globe. I think that's very, very important, so that we can align our resources. Refinement of disease models to calibrate the impact of socio-demographic correlates. And most importantly, learning from COVID. For example, the kind of things that we could do that our previous speaker, Ida, mentioned, or others could do, quick track the vaccine to vaccination. There are other diseases. Today, if I have to create a new vaccine against TB, I can't do that very fast because it takes a long time. So I think this is something where we need to use this model to gain, and that's where we are. Thank you so much for inviting me.
Thank you very much, Seyed, for this very inspiring talk. There's a lot of action in India. It seems like there is much advance based on COVID and the new developments, and the open question is, what will it do to tuberculosis in the future, right? Okay, let's see if there are questions from the floor. Anybody have questions?
I think it's end of the day, so there may not, oh, there are still questions. Yes, please.
Because other diseases are not cared for, like tuberculosis. I'm sure the polio vaccination was down. I'm sure healthcare, prenatal care was down. So usually, if you look at all-cause mortality increases, then you really know the total damage of COVID. Do you have any numbers on this?
Very good question. I'm afraid I don't think we have been able to do that. There are some groups which are now trying to do it, but the data are few and far in between. So we cannot present a picture of Indian picture. We don't have a pan-Indian picture. We are focusing on those diseases, for example, even tuberculosis. We have some data. But tuberculosis is not the only one. We also have other bacterial diseases. We have other viral diseases. But that's a very important question. And I think people are working on it, but we don't have any clear picture emerging on what did COVID do to overall other comorbidities, including, we are also emerging as the diabetic capital of the country, of the world. And that is still about a year or two to gain this dirty advantage, dirty qualification, diabetic capital of the world. But then the fact is people are getting diabetic. How is this affecting diabetes? Now, these are all questions that I think we should be able to answer it in the days to months and years to come.
Thank you. Further questions?
There are two hands.
Yeah.
So we have all seen those pictures of Indians not being able to bury their loved ones. And I always thought that it was just because of COVID, but did tuberculosis play a big part in that too?
Yes, yes.
Okay.
Tuberculosis also because you don't know whether it had reached a stage where people were sick and we don't know if it was TB or it was HIV. HIV is unlikely, but I wouldn't say no, but COVID or other comorbidities.
How much is stigmatization of infected people affecting the Indian health system?
Not for COVID, surprisingly. The stigmatization for people with COVID was not there at all. Nobody, unlike the stigmatization that you see even today for tuberculosis. If I have TB, my friends will not like to meet me, will not like to come closer to me. So that is the reality, but not for COVID, which is rather surprising because COVID overwhelmed everybody. It didn't give you any time. And TB is a slow disease. So you start seeing the effects of TB later on, and you see what the person is going through. With COVID, it came as a matter of minutes, minutes meaning matter of days, and your history. So there was no stigmatization for COVID, but for TB, it is a problem even today.
I have a question. Could you reach 91% vaccination rates? I think Germany could learn something from India. How did you do it?
I think that's very, very simple. We, as I said, we did not wait for a long time for any new vaccine to come. Or we were very, very, very clear. Initially, we were trying to give out our vaccines to other countries. And in fact, prior to Delta, we were giving more of vaccines to other countries than using. Because we were living under the false notion, because there was a drop of that the COVID is over. And we officially declared India is COVID-free. But then we realized that it's not the case. And that is where we jacked up the production. We jacked up and we said no more exporting outside first. So national interest became superior to international interest. And that is the reason mass vaccination was possible. And the digitalized health, marrying digital health was one of the major reasons. I can know that I'm having COVID. Immediately, I'm isolated and I don't become a carrier for others. So all these things cumulatively added to what we could achieve.
But vaccination was voluntary, right?
Yes.
And
yes.
So many people wanted to have it.
Correct, correct.
That's impressive.
And we didn't have any hesitancy to vaccination. Unlike in the US, where some groups did not want to get vaccinated. Even today, I'm told certain groups said, no, we will not. In fact, that is an open question. If you don't ask me as a scientist, I'll tell you, all of us have served as guinea pigs. We don't know what will happen to we as guinea pigs.
Thank you. Are there any additional questions? Now is the time. There's one.
I have a question about the vaccine you talked about. You said there was the first DNA vaccine made by Indians. Is it just a DNA fragment of the virus together with reverse transcriptance, or does it work another way?
It's already published, so I can tell you the reference. But it is, to be honest, I don't remember what exactly it was. But it's a DNA-based vaccine. You don't insert, you don't give anything else. You just give a DNA, which goes inside. It gets reverse transcribed. It gets not reverse transcribed. It gets transcribed into RNA, and then how exactly it works, I'm afraid I don't remember right now. But you do a Google, you can find out more about it. I'm sorry, I don't remember this.